In this podcast, we will learn the science and physiology behind CPAP, called as continuous positive airway pressure. The other name of CPAP is continuous distending pressure, CDP. In this, one applies pressure to airways of spontaneously breathing baby in both phases of respiration, that is, inspiration and expiration. Let us understand how CPAP helps. In a baby with RDS, functional residual capacity FRC of the lung is reduced as alveoli collapse at the end of expiration. CPAP increases the FRC, decreases the VQ mismatch in the baby, thus improving oxygenation, pH, and washing down the CO2. It splints the upper airway, thus preventing obstructive apnea. It dilates the lower airways, thus decreasing the airway resistance. Overall, in a baby who is spontaneously breathing on CPAP, it improves the tidal volume, thus decreasing the work of breathing and improving the minute ventilation in the baby. Overall, pneumocyte 2 function improves, thus production and recycling of surfactant improves in the baby. It improves the lung compliance in the long run. Let me share with you 4 animal experiments which show CPAP is better than conventional ventilation. Here is a preterm lamb. Following ventilation for 24 hours, notice the alveolar wall septa are damaged. Though the functional residual capacity has increased, but this effective surface area for gas exchange has decreased in this animal. In a preterm baby, due to less supportive tissue and thin septa wall, damage occurs to the lung very quickly. Notice in this preterm lamb, following 72 hours of ventilation, the interalveolar wall thickness in conventional ventilation is 3 to 4 times more as compared to another animal in which nasal CPAP is being given. With thickened alveolar wall, the diffusion of gases for gas exchange will be a problem in a preterm animal. Notice that with conventional ventilation, acute lung injury sets in. As shown in this figure, within 2 hours, the alveolar lavage shows significant higher number of inflammatory cells. Also, free oxygen radicals when compared to another animal in which bubble CPAP is provided. This 4th animal experiment shows even the lungs become stiffer at the end of 4 weeks following conventional ventilation due to fibrosis which sets in, shown in green lines. The lung compliance is lower at the end of 4 weeks when compared to another lung in which CPAP is being provided, the blue lines as shown in the figure. The greatest hazard to preterm baby lung is due to endotracheal tube causing biotrauma. In addition, in a non-homogeneous lung, many alveoli collapse at the end of expiration, and sudden opening can lead to atelectotrauma. Conventional ventilation causes barotrauma due to higher mean airway pressure and variable PIP, while in CPAP, the pressure delivered to the lung is much less than conventional ventilation. Unregulated tidal volume in conventional ventilation causes volutrauma to premature baby's lung. So the ventilator-induced lung injury occurs due to biotrauma, atelectotrauma, barotrauma and volutrauma to premature baby's lung. So, CPAP is like a magic. It opens the lung at functional residual capacity for the lung for better gas exchange, keeps the lung open with minimal pressure than in conventional ventilation, thus causing less of barotrauma. Baby is breathing spontaneously, deciding his own tidal volume, unlike in conventional ventilation, hence less of volutrauma. Most important, there is no endotracheal tube, so no biotrauma to baby's lung. Let us see the relationship between the lung volume on the x-axis with the pulmonary vascular resistance on the y-axis. Pulmonary vasculature has least resistance once the lung is opened at the functional residual capacity of the lung. At this volume, pulmonary blood flow is the best. As you can see, once lung volume is reduced, like in hyaline membrane disease shown on left, or increased like in meconium aspiration syndrome, the pulmonary vascular resistance rises, causing right to left shunt. For a baby on CPAP, use of higher pressure leads to overdistension, and inadequate pressure results in reduced functional residual capacity. Both impair pulmonary blood flow due to increased pulmonary vascular resistance. Thus, we must ensure while we use CPAP that the lung is opened at the functional residual capacity, because the blood flow is going to be the maximum, which will result in better gas exchange in the baby. According to law of Laplace, the pressure by which the alveoli tend to collapse is given by a formula 2 times the surface tension divided by the radius. According to this, the smaller the alveolus is, the higher is the pressure by which it tends to collapse. Imagine if 2 alveoli of different diameters are connected to the terminal airways. The smaller alveoli will have a tendency to empty into the larger alveolus, as the pressure in the larger one is less than that of small alveoli. Imagine alveoli are lined by water molecules, which tend to pull alveoli for collapse. This can be nullified by external CPAP pressure, and another alternative can be by reducing the surface tension by installation of surfactant. Thus, a combination of CPAP with surfactant has gone into clinical practice, and it is called as insure technique. Intubate, give surfactant, and extubate to CPAP. So, we learned CPAP is safe as it causes less lung injury. One should give optimal CPAP to open the lung at FRC, as pulmonary vascular resistance is least with maximum blood flow. Use of surfactant and CPAP, also called as insure technique, is beneficial due to additive effect of surfactant and CPAP. You will now learn that maximum dividends of CPAP occur if one provides good delivery room care, uses antenatal steroids in a woman who is delivering preterm, and if there is a team approach for management of baby with RDS. Thank you.